Now, having done over 5,000 total knee replacements from 2006 through 2019, I've had the opportunity to manage stiffness, and I would like to show you some options for doing so and the timing of manipulation under anesthesia after calipered kinematically aligned total knee arthroplasty. The first step when you're confronted with a person that has stiffness after calipered kinematically aligned TK is to go back and check the verification worksheet. Be certain that your distal cuts that you measured with the caliper are correct and equal that of the thickness of the femoral component distally after you compensate for cartilage wear and for the thickness of the kerf of the saw blade. So in this case, it was a varus knee. The distal medial cut was 6. The distal lateral cut was 8. You add a millimeter back for the kerf of the blade, makes it 7 and 9. On the medial side, you add 2 millimeters for cartilage, which makes it 9, and therefore they both equal the thickness of the distal condyle, and so they should be recorded on the verification sheet. We now do the same for the posterior resections, and we expect the thickness of the posterior resections, posterior medial, posterior lateral, to also equal the thickness of the condyle of the femoral component, which is 8 millimeters thick. The posterior medial cut was 6. We went back and took an additional millimeter off. The posterior lateral was 6. We took an additional millimeter off. That made 7. 7. Add 1 for the thickness of the saw blade, and we have 8. So in this case, we can go back and look at the verification sheet, and we know the femur is kinematically correct, meaning that we've restored the native joint lines. So this is the type of knee that responds well to a manipulation under anesthesia. So you can always start with self-administered flexion extension exercises. We found they are more effective than the use of physical therapists, which tend to hurt the patient. So before the MUA, I asked the patient to, at least for a month or so, try prone extension exercises for loss of extension. So we have them put, if they're painful, a 2-pound weight, ideally a 5 to 10-pound weight on their ankle, sit off the end of a surface, and let the knee straighten, trying to get the tip of their toes to touch the floor, and then hold that position till they have discomfort, flex the knee to take it off, and then do it again and repeat it 20 times, several times a day. They can work on flexing the knee by sitting in a chair, hooking the normal leg, if you will, in front of the operative foot, the foot on the operative leg, and then just drag the knee back until they feel a sense of tightness but no pain. Hold that position and sustain it for 10 seconds, and then pull again until you get a little bit of discomfort, and stop there once again and sustain that position for 10. We call that one repetition or one cycle, and we repeat that 10 times, several times a day to regain flexion of the knee. When this is ineffective, then an early or even late manipulation under anesthesia is usually effective as long as the femoral component is kinematically aligned. So let's look at a case. This patient was seen in the preoperative area for a left calipered kinematically aligned TKA after having a right kinematically aligned TKA 6 months earlier. And the patient really had no complaints of the right knee, but we noticed it didn't flex all the way. So the examination detected this loss of flexion even though the patient had no symptoms or complaints. And we have learned this over the years that an MUA, even at 2 or 3 years out, in a patient that had calipered kinematically aligned TKA, will be successful at restoring motion. So this is the patient, and you can see that on the right side is the one that we're going to do, is the one that we did the total knee on, excuse me. The right one is the one that had the calipered kinematically aligned TKA 6 months before, and the left ones we're going to do that day. So there's a loss of flexion, and we give it one push, and there's usually some adhesions that stretch, usually in the suprapatellar area around the distal end of the quad, and then that plastic deformation persists. Doesn't recoil, and as you'll see here, you can just simply lift the legs up, and you can see that the flexion has been restored. So the next morning when we see the patient, you can see now that the left operative leg is now facing us where it was away from us in the previous video. We have 90 degrees of flexion the day after, but notice how well the right knee bends. And he notes immediately a little less stiffness in the knee, a little less discomfort in deep flexion. And so manipulations under anesthesia after a calipered kinematically aligned TKA can be done later. They don't need to be done in the first 4 to 6 weeks. The ease of the manipulation for anesthesia is due to the accuracy of the verification checks as they result in identical coronal and axial alignment, as we'll show in this patient. So here we have the 2 knees done 6 months apart, You can see that the joint lines are restored, the limb lines are restored, everything's the same. You can see that the IE, there's no malrotation of the femoral and tibial component. Well, there is, but it's less than 6 degrees, which is well within the tolerance of acceptability. And so the repeatability of the operation, based on the verification checks and decision trees, is so high that you get this consistent surgical execution and the ability that when mild stiffness and flexion results, you can do the manipulation. Case 2 is a patient that reported incomplete flexion in the anterior knee pain 13 months after a right calipered kinematically aligned TKA. It was done on a knee that was a floating knee many years before due to a fracture of the femur that was treated with plate fixation and cast treatment of a tibial fixation. We performed this MUA at 13 months, and this is when I learned these longer time intervals from surgery to manipulation does not preclude a successful manipulation under anesthesia. We went back and we didn't have the verification sheet at the time, but we did have intraoperative photographs of the implant, of the bone resections of the distal medial femur and the posterior medial femur and the distal lateral femur and the posterior lateral femur, and those cuts correspond to those of a 9mm implant distally and posteriorly when we factor in the wear for the varus knee on the distal medial side and the curve of the blade. So this was a good position of the femoral component, and you can see that on her long leg CT scanogram, the plate fixation after it had been removed showing the femoral fracture, and you can see that the tibial fracture down below, and we had no malrotation of the tibial component on the femoral component on an axial view, and this was her at 13 months. And once again, excellent extension. So kinematic alignment has a very high success of getting the extension back, but occasionally they don't get the knee moving, and here we have once again this sort of loss of flexion. Many people would not even think about manipulating this, but it makes the Oxford scores go up, the forgotten joint score go up, and so just one push, that's all it took. This is at 13 months. And once again, you'll feel the adhesions in the anterior part of the pouch. And go back and just confirm whether or not that you achieved a flexion symmetric to the opposite side, and indeed we did. And so we bring this patient back at 2 weeks, and you can see her bend and flex the knee, and her discomfort in the anterior aspect of the knee is gone. She's happy. She can get to the gym. And her Oxford knee score improved during that 2-week period from 25 pre-op, if you will, to 38, and then at 2 weeks after the manipulation went from 38 to 42 for a 4-point improvement. The third case, this is a patient where they did not have kinematic alignment, although we intended to do so. We used a unknowingly poor-fitting patient-specific guide that didn't set the femoral component kinematically and did not restore the native joint line. And not restoring the native joint line with the femoral component caused a difficult recovery, prolonged stiffness in the knee, and the manipulation, while successful, still was difficult to perform, and the recovery was too long. So this shows the downside when you don't adhere to the principles of kinematic alignment and deviate from placement of the femoral component to those of the prearthritic native joint line. Surprisingly, this patient did well at a year. But let's look through the case. This patient really just had medial arthritis on the tibia. There was really hardly any cartilage wear on the femur, so all 4 of the bone resections should have been the same thickness. We should have had an 8mm resection distal medial, 8mm distal lateral, 8mm posterior medial, 8mm posterior lateral. And so they should have been 7mm thick for an 8mm femoral component. So when we measure the thicknesses, they should have all been 7. Simple as that. We planned the surgery back in 2009. It was treated with PSI, the Otis knee. And at this time, we didn't understand it, but this was poor segmentation where the tracings of the trochlear groove were not close to those of the joint surface. This caused, in this cadaveric model, which just demonstrates the situation, where you can have some IE malpositioning and flexion extension malpositioning that causes the guide to float, and you can seat it, but it may be in the incorrect position. That's what happened in this patient. Remember, all of these resections should have been 7mm thick. You can see that the resection distal medial was too much, therefore loose medial and extension. Posterior medial is even greater than distal medial, so it would have been even more loose in flexion. Distal lateral was actually tight in extension, and posterior was even much looser than in extension. So this is more like a mechanically aligned knee where the bone resections do not match those of the condyles of the femoral component after you correct for the kerf of the blade and the cartilage wear. You couldn't pick this up on a postoperative long leg scanogram. Limb alignment looks good, but this is the MUA at 3 months. Patient lacks extension. Why? Because we didn't cut enough off distal lateral, which jammed the joint laterally. Flexion should be easy to regain because we over-resected posteriorly on both condyles. And if you watch the manipulation, you can see that we have a very, very difficult time regaining the extension. The flexion isn't too bad, but this patient struggled, and it was due to surgical error, and all could have been minimized if we knew and measured the verification checks back in 2009. So here we are. Flexion, as we mentioned, comes back pretty easy because we over-resected posterior medially, but that can lead to flexion gap instability of fusions and exercise intolerance with activity. A little harder to get the extension back, and it's really not that great. But when we talked to him at a year, he actually gave us an Oxford score of 45, but was upset that it took him too long to recover, and he's not in a rush to get the other knee done, and he's not in a rush to send his friends to us. How about a third option, arthroscopic lysis of adhesions and a release of the PCL? I've done this 2 times. The release of the PCL can be helpful, but I think this small limited experience that I have is too little for me to make a recommendation. The fourth option is an open lysis and adhesions and insertion of a thinner tibial insert if you have the room to move in that direction. Once again, I've had 2 cases of these over 13 years, and I think I have too little experience to make a recommendation.